Welcome back, everyone. We're going to continue our toxicology series with taking a look at hypnotics, sedatives, and other recreational drugs. Let's start with marijuana and cannabis compounds. These are derived from cannabis sativa, and controversy does exist whether there is a clinical use or legitimate medical use and legalization. For the pathophysiology for marijuana and cannabis compounds, we're looking at the psychoactive ingredient, which is delta-9 tetrahydrocannabinol. It's usually smoked, but it certainly can be ingested, and short-term effects include tachycardia, balance and coordination problems, and increased appetite. For assessment and management for users of marijuana and cannabis compounds, there's really not life-threatening emergencies associated with it. You may, however, have to provide some emotional support and supportive care, given that one of the side effects of use is oftentimes anxiety and paranoia, and this may drive the user to call EMS for assistance, and some reassurance may be needed there. And if the patient is significantly anxious and there are cardiovascular implications to the anxiety outside of just normal anxiousness, or if there are profound implications, then the paramedic provider may consider the use of benzodiazepines for a sedative agent. Spice is a synthetic blend of cannabinoids. It can be much more dangerous than marijuana, given that the spice can contain some various chemicals that may have additional implications other than just marijuana use itself. You can have varying patient presentations based on these chemicals that are added, and you may need to provide supportive care, and advanced providers may need to provide additional fluid resuscitation with fluid boluses or antiemetics if there's excessive nausea, vomiting, or hypovolemic type presentation associated with it. Hallucinogens cause a distortion of sense and perception. The experience is oftentimes affected by the user's previous drug experience, how much of the medication or drug they've taken, the user's expectation, and the social setting. They're classified as either synthetic or naturally occurring. LSD, or lysergic acid diethylamide, is not as common as it once was, but it certainly is still fairly common. The physiologic effects can include things like mild tachycardia, palpitations, and changes in the pupils, mostly mydriasis. Assessment and management, again, it's largely supportive care. You can help reduce some of the implications of the drug by limiting some of the sensory inputs. So turning down the lights, reducing noise stimulus, and removing the patient from the environment that is excessively stimulating, and that can help them manage some of the symptoms while we wait for the effects of the drug to wear off. PCP is a dissociative anesthetic with hallucinogenic properties. It's typically smoked or snorted. Small doses can produce symptoms of intoxication. Users may display some extraordinary strength, have a sense of invincibility, which can lead to subsequent trauma, which is oftentimes where EMS gets involved, and they may have a lack of awareness of pain in general. Ensure patient safety. Again, paramedic providers may need to consider intramuscular sedative for the excessively combative or aggressive patient. Other supportive care, O2 if the patient's hypoxic, provide a safe transport and monitor appropriately. Ketamine is used pharmacologically for indications, both pre-hospital and in-hospital, as well as used recreationally. At low doses, the user presents with mild inebriation, senses of euphoria, and increased sociability. At higher doses, though, the patient may experience things like pronounced nausea, dyskinesia or difficulty moving, and complaint of kind of entering into another reality. Secure the patient well, manage ABCs accordingly, provide oxygen if they're hypoxic. You can establish vascular access for AEMTs and paramedics, but ultimately we're just looking at providing a safe transport. Peyote and mescaline increase sensitivity to sensory stimulation. Symptoms include dilated pupils, increased pulse rate, mild hypertension, and increased body temperature. Pre-hospital care is supportive. Again, with this, kind of like some of the other stimulants that we had looked at previously, body temperature may be of concern, so you may have to engage in some active cooling measures. But largely, with these recreational drugs, you're providing psychological support, monitoring vital signs, and O2 as needed for the patient. Psilocybin mushrooms contain hallucinogenic substances. The onset's generally about 30 minutes, and the effects can last 4 to 6 hours. Some of the symptoms that you may be encountering pre-hospital is vomiting, mydriasis, and mild tachycardia. Management of ABC, supportive care, establish IV access. Sedative hypnotics do have a wide range of use. They function as CNS depressants. Oftentimes, these medications are used for anxiety reduction and sleep aids. They do have a high potential for abuse, and so encountering overdoses or excessive amounts of these is not relatively uncommon. First, we'll talk about barbiturates, which come in 4 basic actions or action configurations. You've got long-acting, intermediate, short-acting, and ultra-short-acting. They create a mild to moderate sense of intoxication, much like alcohol intoxication. But as the dose increases, the patient can become increasingly lethargic and start having a low level of responsiveness. So for overdoses of barbiturates or barbiturates, the management is going to be predominantly around airway control and monitoring oxygenation with SpO2 monitoring and capnography. Ventilation may need to be provided, and if shock develops, we may need to consider fluid resuscitation for ALS providers. For long-lasting medications, you might want to consider the administration of sodium bicarbonate to help alkalinize the urine. We generally don't give out sodium bicarb a lot in the pre-hospital world, and so I would consider consulting online med control prior to doing this, just to ensure that we're not creating some additional underlying issues for the patient, underlying metabolic issues. Abrupt cessation of use of barbiturates in long-term users produces withdrawal symptoms that typically last several days and start within 24 hours. Rapid transport can be indicated. Minor withdrawal signs include things like restlessness, insomnia, diaphoresis, with severe signs being delirium, hallucination, psychosis, and hyperthermia, which you're going to need to manage accordingly. Benzos or benzodiazepines, these are members of the sedative hypnotic family, and they're used to stimulate the gamma aminobutyric acid pathways, which results in sedation and reduced anxiety. When we use these medications in the pre-hospital world, we prefer the IV route, but they're often prescribed at home use and come in pill form. Single entity overdose for benzos has a low morbidity rate. Common clinical effects include things like altered mentation, drowsiness, slurred speech, general incoordination. Management, airway support for any of the sedatives that we see, regardless of their origin. So we may need to manage airway, establish IV access, and advanced providers may need fluid bolus administrations to support circulatory status. There is a reversal agent for benzodiazepine. It's flumazenil or romazicon. We generally shy away from giving this in the pre-hospital world because if the patient is prescribed benzos as part of their seizure control regimen, the romazicon or flumazenil will prevent the effectiveness if we need to manage seizures with benzodiazepines. So we generally don't administer that pre-hospital, but some services may carry. So we also have a class of drugs that are commonly used in the pre-hospital or off-label or without prescription use, and those are erectile dysfunction medications. Phosphodiesterase inhibitors are things like sildenafil, tadalafil, and vardenafil are common. Symptoms for this, remember that this class of medications were originally created as cardiac medications and subsequently rebranded and reused once the effects for erectile dysfunction were recognized. And so symptoms can include elevated levels can create symptoms such as cardiac abnormalities. Prolonged priapism is also a risk. Supportive care is usually sufficient unless they've taken an excessive amount or they're taking them in combination with things like nitroglycerin or other vasodilatory medications. Cocaine and other stimulant drugs, for those we're going to need to manage through serial boluses of normal saline. We talked about that in our stimulants lectures. Amyl nitrate may have a hypotension that results, and ecstasy is another stimulant. And the concern with ecstasy would be temperature management, again, from that sympathetic overtone. Dextromethorphan, or DMX, also called robotripping, is or was common for quite some time, particularly amongst young teenage adults of higher socioeconomic status that may not have access or readily available access to other street drugs. It seems like cough medicine, which DMX is found in common cough syrups, was a usable choice for this population group, and can create some pretty profound recreational responses. Effects from large doses include hallucinogens, loss of motor control, dreamlike euphoria. Severe hyperthermia can also result from DXM, so it's worthwhile to be mindful. And while I don't think that there is a physiologic addiction component to it, there certainly is a psychological addiction component, and it has been over a course of recent decades relatively popular amongst high school students. Drugs that facilitate sexual assault, you've got things like GHB, or gamma hydroxybutyrate. It's a colorless and odorless liquid. It can exert its effects within about 60 minutes and can produce a hypnotic and sedative effect. Treatment for this is going to be supportive, monitor oxygenation and ventilation. You may need to assess ventilations for ventilatory support, IV access and rapid transport, and then you may have some additional considerations here if you suspect that the patient was indeed a victim of sexual assault or sexual abuse. Roofies, or Rohypnol, potent benzodiazepine. They're often combined with other drugs that suppress the central nervous system, and they're illegal to make and distribute, but they do show up. So this is another drug that's often used to facilitate sexual assault. So while your management is going to be similar to that with other benzodiazepines, it will you need to take into account other potential psychological factors that may be going on, or physical assault factors if the patient indicates a potential for sexual assault or sexual abuse.